to our Racialised Health Inequalities community of practice. I'm Mel Weldon, and I head up the team, the Scottish Government team, leading on racialised health inequalities and anti-racism. And it's so great to see so many people here for the relaunch today. And thanks to each and every one of you for making time, and also to those of you who've joined our working group. So we set that up to plan future meetings and want to include as many of you in that as we can. We circulated revised terms of reference for the community of practice, so I'm not going to go through them in any detail, but suffice to say that in essence, when I think of the community of practice, I think it's about creating common purpose with regard to anti-racism and racialised health inequalities, and working together to grow our understanding of how racism operates, how to challenge it, how to dismantle it, and how to create lasting change. So that's how I sort of conceptualise it. And hearing from experts and sharing good practice and ideas in Scotland or further afield is a really, really important part of this. And so too are the discussions that we can have at these events, the community of practice events, and through new connections, new networks, new opportunities for collaboration that I'm sure the community of practice will foster. I think it's fair to say that there hasn't been a concerted effort like this across health and social care in Scotland, and whilst we have some ideas about how to go forward, we're totally open to suggestions about what we might best do. And as I said, some of you will be on our working group, but just get in touch with the team. You know who we are, so we'd love to hear from you. I just wanted to say a quick word about what's been happening since the community of practice last met, which I think is probably over a year ago. So just a few things to highlight. The senior steering group, which oversees this work, and it's co-chaired by Safia Qureshi, Director of Evidence at Health Improvement Scotland, and Richard Foggo, Director of Population Health in Scottish Government. The group continues to meet every 3 months, and the things that it's focused on, is very focused on, is leadership and workforce. We've also set up a new group, and that's co-chaired by Public Health Scotland and Scottish Government, to improve race and ethnicity data. And within Scottish Government, there's lots of work going on to build anti-racism leadership, including anti-racism objectives and sessions delivered by CRER for senior leaders in their teams. And we know that other organisations within the health and social care family are also actively considering how to become effective anti-racism organisations. And just a couple more things that I think might be of interest. More recently, in the programme for government, published in September, the government reiterated its plans to set up an anti-racism observatory for Scotland, consistent with its commitment to eradicate racism, and that was the language used, so pretty strong. And the Scottish Government team has been meeting with health boards to learn about and to learn from the work that they're doing, and that's been absolutely great. We warmly welcome the time that people have given up for those meetings. So, there's a lot going on. So, without further ado, I'm really delighted to introduce our guest speaker, Dr. Gwinnetta Curry. We have circulated some biographical details, but let me just tell you briefly a bit about her. Gwinnetta is a reader in race, ethnicity and health at the University of Edinburgh's College of Medicine and Veterinary Medicine. Her research interests include racial and ethnic health disparities, maternal health, and Black family studies. She's the co-author of the Uncover COVID-19 Evidence Review, What is the Evidence on Ethnic Variation on COVID-19 Incidence and Outcomes, and Sharpening the Global Focus on Ethnicity and Race in the Time of COVID-19, which has appeared in The Lancet. Gwinnetta is a member of the UK Medical School Equality, Diversity and Inclusion Alliance and the Office of National Statistics Inclusive Data Task Force. She also serves as the inequality expert for the Royal College of Physicians Committee for Ethical Issues in Medicine. And I'm really delighted to say that Gwinnett is about to join the steering group I mentioned earlier, overseeing the work we're doing across health and social care to address racism and racialised health inequalities. So just to say that after Gwyneth's presentation, as billed, there'll be time for Q&A and discussion, and we really welcome your active participation in this. As Andrew's mentioned, you can put questions in the Slido link in the chat, and you can also vote on questions. So that's all I wanted to say by way of introduction, and happy to hand over to Gwyneth. Thanks, Gwyneth.
Thank you, Melanie, for the introduction, and thank you for inviting me to speak today, and as well as to serve on the steering committee for this group. I'm going to be using PowerPoint Live, so just give it a moment, and we will load the slides. Let's see. This is my first time using PowerPoint Live, but it seems to be more accessible for everyone. Let's see. Let me know when you can see this, and then I'll get started. It's loading slowly. What's happening?
In the meantime, I'll just use the time as a reminder to, yes, please do use Slido for your questions as they come up, or then save them up to ask them in person in the Q&A section.
Perfect. Hopefully everyone can see the slides now. The title of the presentation is Structural and Systemic Racism in Health and Social Care, How It Works and Ways to Address It. So today, I'm going to start off with some key definitions. Some of you may have heard of some of these definitions and had a different explanation of them. Some of it will be your first time hearing it. I'll go into how systemic racism operates in society and environment, and how it affects healthcare and social care, and also some of the impact of policy on health outcomes for certain groups, and also give some ideas of what systems and institutions can do to address systemic racism. And I've also provided some further reading if you're very interested in continuing on learning more on this area. So I teach medical students, and in the States, I taught undergraduate and graduate students. I'm starting my timer. Undergraduate and graduate students, and a lot of them, you know, some people had zero knowledge and some people had some knowledge, and it was always important to start off with definitions. So today I'm going to start off with a, just a comparison definition of racism versus race. Sometimes when you look at the analysis done in demographic data, even in some of the published data, they'll say, okay, race has caused said outcome. But race didn't cause the outcome. More likely, racism, the experiences of racism, caused particular outcomes. And this definition by Brenda Fields is one that I ascribe to. Racism is the assignment of people to an inferior category and the determination of their social, economic, civic, and human standing on that basis. So deciding where people belong in the rungs of society. And the way society has been structured, inevitably, in the UK, as well as across the US and other places, Black and brown bodies have been placed at the bottom, experiencing higher rates of unemployment, as well as disparities and illnesses. Race denotes the state of mind, a feeling or being, rather than a program or pattern of action. Okay, so we know that race is a social construct. For a long time, scientists looked at race as something that is real, but as a social scientist, we know that people are ascribed to different racial categories. What does that mean? So how does society see you? Where do you belong in this, this racial hierarchy? Society denotes that. And I think that you can call yourself, a different identity, but society treats you a certain way. So when we talk about racial identities, that's what we mean. So I've been categorized as a Black woman. So that is my racial category. And that's how that operates. Here in the UK, a lot of people use race and ethnicity interchangeably. That is something that we rarely do in the States because ethnicity is more of a cultural and religious practices will denote what your ethnicity is, okay, versus race as it is a social construct. So when we talk about systemic racism, I was trained at Texas A&M by Joe Fagan. I mean, Joe is still teaching till this day, and he's well up in his 80s. He's not retiring. He really enjoys his work, but he's one of the first people to, write on systemic racism, and he defined it as the complex array of anti-Black practices, the unjustly gained political economic power of whites, the continuing economic and other resource inequality along racial lines, the white racist ideology and attitudes created to maintain the racial hierarchy, pretty much. Now, when we think about acts of racism, most of the times we're talking about overt racism. So someone being called the N-word, various racial attacks, be they physical or verbal. So often, those are not the ones that happen on a day-to-day basis, particularly in the UK. Covert racism is something that is very pervasive throughout society, and it can be overlooked in a lot of ways because it's not overt, right? It's not something that someone didn't call you a name. You were not attacked in that way, but you still experience racism in the way it's defined as covert racism, denying employment, housing loans, limiting admission of people of color. If you look across the institutions in the UK, Black people still account for less than 1% of the Black staff across the UK institutions. And that has been the same for well over a decade, right? So those are some things that need to be addressed. And it's not calling someone the N-word, it's not an attack, but it's the denial, right? It's the denial of access to certain spaces. And you see the same thing in housing. You'll look at different neighborhoods and, it's not an accident that there's not any Black or brown families that live in this space. This happens on purpose, right? Eduardo Bonilla Silva and Joe Fagan talk about this white racial framing. Joe Fagan did a study where he has students take journals. So mostly white students, they took journals into various spaces and they would write about these experiences where they're with their white friends or where they're with mixed company. And they talked about how it was this backstage, so meaning out of the public eye. This is just us hanging out at the house, the jokes that they would say. So they will say, this is considered backstage racism versus front stage where, you're in front of everybody and you may say something racist. So the students took these journals and they wrote about these experiences, which led Joe Fagan to create something what he calls the white racial frame, which is the overarching white worldview that encompasses a broad and persisting set of stereotypes. So we think about the stereotypes that's pervasive in societies of, different behaviors or criminal acts that you ascribe to certain bodies versus others, right? Prejudices, ideologies, and images, right? And images is something that's, used a lot to denote, okay, this is what a criminal looks like. This is what someone that belongs in this space looks like, right? And people do it without acknowledging it, and it happens so often that it's just intuitive to some. And I will show you, this is a great example. So if you look at these two pictures, Christopher Watts, this is the image that they used after he killed his wife and his two daughters. So you go into the media and they're telling you about this criminal act, this dangerous person. This is the image they use. The image of a family man standing there, smiling, but he just killed his whole family. That's not the image they use. When it came to Trayvon Martin, they use many images of him being, now this is, if people that don't know the story, he was a young Black boy walking in a predominantly white neighborhood. He went out to get some Skittles and an Arizona sweet tea, and he was on his way home, okay? And when he was on his way home, George Zimmerman, who he thought he was protecting the community, killed him because he felt that he didn't belong in this space. Okay, the images of what they used for George Zimmerman, or for Trayvon Martin, was vastly different than what they used for Christopher Watts. So I asked the question, what does a criminal look like? Because in media, they create these images that they show over and over again in terms of the Black male versus images of like Christopher Watts. He clearly is the worst of the two here, because this young man, Trayvon Martin, was a teenager. He was innocent. He was simply walking home. Christopher Watts killed his whole family and tried to cover up the murder. But these are the vast different images that they put out in the media for you to say, oh my gosh, I can't believe he did that, such a family man, right? So you still have sympathy for him. For Trayvon Martin, the image they put up with him of, with hoodies or doing something with his friends, he's seen as, oh, a thug, someone not deserving of life, right? So these images lead to various racial biases, and some of these biases go into medical practices. So this was a study of racial bias among physicians. Recent studies suggested that even when Blacks gain access to the healthcare system, they're less likely than their whites to receive certain surgical or therapies, whether disparities in treatment decisions are caused by differences of income, education, social cultural factors, or failures by the medical profession. They're unjustified. So whether this is also an example I give to my students. There was a study. They had a father who was playing soccer with his Latin American father playing soccer with his kids. He broke his leg playing soccer. White man had the same injury. He was golfing with friends. They both go to the hospital. One was taken care of immediately. The other one was put in a stent and sent home and told to go see their GP. So you think about the amount of pain this person would have been in versus one who was treated immediately. So these type of disparities in treatment happen so often. And it's due to this, subconscious bias sometimes of, okay, racialized minorities are always seen as, drug seeking, right? So they don't, or in the US in particular, they are assumed not to have insurance, okay? So if you don't have insurance, they know that they may not get paid fully, or it will be a situation where they're chasing up the funds, okay? So these type of biases occur, and they're pervasive throughout the medical practice. Bias may represent overt prejudice on the part of physicians, and more likely could be a result of subconscious perceptions rather than a deliberate act. So some of these things are not deliberate. Some of these things are, again, subconscious. It occurs when a patient's membership to a targeted group, be it Black, brown, or other, automatically activates a cultural stereotype in physician's memory, regardless of the level of prejudice that the physician has, okay? So if you think about, you've probably seen the movies with the people in New York standing on the side of the road, hailing a taxi, okay? And Black men have a very challenging time getting a taxi to stop for them in New York. This example was given because if you compare it to how physicians consider whether they're going to do an organ transplant or not for Black people, it falls along the same line. These assumptions, these stereotypes of Black people not following post-operative care, have been pervasive, as well as the pain thresholds. We'll get to that later. But survey results show that physicians perceive their Black patients as less intelligent, less well-educated, and less likely to have personal characteristics most conducive to successful rehabilitation from cardiac procedures. So if you just think about that, they are putting someone's life at risk because they perceive that they will not follow the medical guidance simply based on their race. All right. So these type of things lead to a disproportionate amount of Black and brown people dying unnecessarily from things that could have been easily treated through medical practice. Unconscious aversion as a form of racial bias. So aversion is like a mental attitude or opposition or repugnance, a fixed habitual dislike. So some people have just a explicit dislike of certain people. So when they come into their office, they're, all they see are the stereotypical makeups of that racialized body. It represents a subtle, often unintentional form of bias that characterized by many white Americans who possess strong egalitarian values and who believe that they are not prejudiced. So in their heart of hearts, they believe they're not prejudiced, but when they see the patient come into their office, they also it activates these very stereotypical views of that patient and can have a negative impact on how they treat the patient. And these things are unconscious, right? So if it's unconscious, how can it be addressed? And they have these trainings for unconscious bias, and some people have said it's not very effective because if it's unconscious, how do you address it? But it does increase awareness. If you do unconscious bias trainings, it could increase your awareness that these things happen, and maybe you'll take a beat before you move to the next step to make sure you are doing everything to address the needs and concerns of the patient in front of you. I really like this particular graph, and I thought I'd put it in here. It's from Harvicher and Bata. It says tackling health inequalities through public health practice. Now, this says that institutional racism, class oppression, gender discrimination, and exploitation are the root causes of disparities in health outcomes. And if you see down the middle how these institutional racism and class oppression and so on can lead to an imbalance in power. So power and wealth are both things that people use to live a better life, to get more access to resources and more autonomy and control. So if you see in that middle section, they have labor markets, housing policy, education, social safety networks. Think about social capital. A lot of people don't consider the social capital that you have just by living and working in certain neighborhoods, your children going to certain schools. Your children go to school with other kids whose parents are academics, physicians, or, parents have money or their parents have money, these generational wealth. It's a vastly different social network than they have when they live in deprived areas when parents are struggling to pay their bills. They may be struggling with drug addiction or other addictions. And so that social capital has a huge impact on the possibilities that this child see for their future, okay? So it starts at a very early age. Now, if you go down to the social determinants of health, now a lot of people look at the social determinants of health, and they've been teaching this for years, and the U.S. has just maybe 2 years ago now, I think, made racism a public health concern, and I argue that it should also be considered one of the social determinants of health, okay? Because the experience of racism has direct impact on health. But on social determinants of health, if you look at the living wage, quality education, transportation, availability of food. Food is another big area that needs attention, because if you look at the food that's available in the deprived areas versus the least deprived areas, it's vastly different. And we know that to live a healthy, balanced life, right, to eat the healthy fruits and vegetables, they need to be made accessible. So this can lead to different psychological stressors and unhealthy behaviors. So if you don't have the food you need, you don't have the job security, and these studies have been done. So if you have an area, and especially in an industrial area when there were a lot of factories, there were factories there, the community was thriving. When they took the factory away, they closed it down due to changes in the economy. We saw a huge increase in depression, alcohol abuse, and drug abuse just by removing the factory that was in the area that was providing jobs for that community, right? And so that led to poor health behaviors and, again, poor health outcomes. Housing discrimination. Black, African, and Arab groups had the lowest rate of home ownership compared to 68% of white British populations. And this data is from ONS in England. And housing discrimination is important because where people live, again, has a direct impact on the resources they have available to them. And if we think back to the times of COVID, although we're not totally free of it, but we're no longer dealing with lockdowns. Housing was very important during the lockdown time because if you think about being locked in a space, you have 1 hour outside your home to exercise. Your space at home was, supposed to be your safe haven. So if you lived in a deprived area with maybe high levels of violence or poor ventilation, your chances of catching COVID was much higher. The multi-generational housing was a major issue. BAME, I put in quotes because I don't believe in putting everybody together, but Black, Asian, minority, ethnic households have lower access to quality housing and more likely to live in overcrowded housing, and more likely to face homelessness, right? The Race Equality Foundation showed that Bangladeshi households 63% and Black African households 75% more likely than their white British households to suffer from housing deprivation. So if you think about that, and you think about what housing provides for you, you could understand how some of these health inequalities are persisting, because where people live at has a huge impact on their life chances. Not only the housing, but also the air around their house. So if you live in a urban space with a lot of traffic, the rates of asthma are significantly higher. And so, because the air quality will be higher. And a lot of people that live in these spaces happen to be from racialized minority backgrounds. And so they're suffering disproportionately from chronic illnesses such as asthma. Educational attainment is another big area. You know, it's always been stated, you increase education, you increase opportunities, and better health outcomes. There was a book written by Sir Malcolm Monmouth, Status Syndrome. It was really well done, but it really showed that the educational gradient. So as you increase education, you improve your health outcomes. Well, if you look at the data, it shows that mixed white and Black Caribbean pupils were nearly 3 times as likely to be permanently excluded than their white British counterparts, right? So if you're excluded from the education system, it's no way that you could progress, through education and society. Your opportunities have been stunted. Unemployment, Black people had the highest unemployment rate in the UK of all ethnic groups, 9% compared to 4%. Right. So a lot of the times when we look at the data, we can only find data from England and Wales that are broken down through ethnicity. But Scotland also has the same issue. So if you look at the unemployment rates from 2011 to 2021, consistently, minority ethnic groups had higher rates of unemployment than their white counterparts. The last data point was 2021, which shows 6.5 for minority ethnic groups and 3.8 for white ethnic groups. So if you look at the map, you think about, this is through COVID, this is quote unquote post-COVID era, and we still have these same issues persisting today. Okay. And to understand this, it's really important. There's a group called Prospect, and they did some amazing research, and they showed that, racialized minorities actually have a really good, high rate of professional certifications, as well as, high levels of degrees. So if they do make it through the education system, they do have pretty high standards. But the issue is becoming employed. Some of the people they interviewed talked about having to take PhD off of their CV just to be hired in Scotland. And I think it's important to know that this is Scotland, because when we talk through these, it's a lot of people decide, oh, well, that was England, oh, that happened in America, that doesn't happen here. No, this was in Scotland. These people lived in the Glasgow, Edinburgh area who were interviewed, and some of them even received their degrees from these institutions, but they were unable to find jobs while they had PhD on their CV. So this is something that's really important to kind of focus on. Police harassment. So when police harassment. So when the killing of George Floyd happened in America, it was a wake-up call for many. Black Lives Matter, was on front page news. Everybody was paying attention. And, it was seen as something that happened in America and, not necessarily an issue we have here. While police here don't carry, they all don't carry guns like in the US. US, kind of love our guns. But they do have the same issue here in terms of police harassment. Black ethnic groups experience the highest rates of stop and search of all ethnic groups. And this was something that was really problematic during the pandemic. So, as you knew, we had 1 hour of time outside our homes to exercise. Black men and boys in particular felt very targeted during that time. Some of them spoke about going out for a jog for exercise and being harassed by police because of the assumption that they was running from a crime or they were involved in some sort of deviant behavior. All right, so this is the issue that we have here. We can't necessarily just sweep it under the rug and say, oh, that happened in America, that doesn't happen here. So this, I was part of a group called Co-Power, and they they had a project, and they provided spaces for young Black men, since they were having this issue with hypersurveillance, to go during the pandemic for exercise. And I want to show this clip. Um, this was this was produced by a scholar at Southampton. Her name is Professor Florence Asai. And let's see, hopefully everything works. Let's try it out. Let's see. Okay, hopefully everybody can see this. I'm going to just show a couple minutes, okay? Okay. Start from here.
Winetta, we can't hear it. We can't hear the video.
You can't hear it? Okay,
No,
hold on
we
one
can't
second.
hear it.
Okay, one moment. Can you hear now?
Yeah, brilliant.
Yep.
Thank you.
Thank you.
Are you treating me like this in front of my kids for allegation? There is no allegation. And you hurting me.
I'm not trying to hurt you. I just want to get you out of the car.
And you taking my property.
See it in your face.
You searching my phone for what? For what?
Stay in the car.
Chill. Chill. I'm asking you a question. You arresting me. You kidnapping me with no reference. This is kidnapping. This is the second time you guys kidnapping me. And I was like, what? Great, but they're like trying to make it look like they're trying to be professional. But you cannot be professional if you do that in front of my wife and kids,
What was that for you?
So the kid, I was shocked. The kids were upset because
Crying.
they have, the little ones, they have never experienced it. I've never experienced the arrest, and especially arrest of my husband and accusing him of such a thing, which I did not even I would not even believe it for a second.
By the way, they didn't wear no mask, no even mask, and this is pandemic. And they're supposed to be, they're finding people like us. Nobody. I complain all that. They blame her for staying on the scene with the kids. I think you're just gonna walk away. My kid's gonna walk away. That would destroy them because you just kidnapped me.
And when we see 5, 6 police officers on our dad, like holding him, grabbing him, it's like, oh my God, we are going to be one of them families that are like praying for our dad and like who are attending our dad's funeral because he's been killed by the police.
We haven't properly experienced this before. Like, it was the first time that we saw our dad getting arrested like that. And like, know that there was like so many police like officers on him. It was just like, we didn't want to see that. Like, we weren't meant to see that, in my opinion.
My skin become a criminal in this town. I become a target because of my skin. I can't see anything else. I don't sell drugs. I don't walk around with guns. I don't take drugs, even on my lowest points.
All right. So that was a short clip. I'm trying to go back to the slide. That was a short clip, but Ahmed experienced a lot of this type of abuse throughout the pandemic. Again, his little children are there seeing this as well. His family simply trying to use the 1 hour they have outside of their home to do their exercise, just going for a family walk. Something that we probably, did without even thinking, like this is what you do. And he was harassed over and over again. Think about what that did to his children and not only to him. Unfortunately, we just found out last year that he died. All of that stress that he experienced took a toll on him. And he was a fit guy. Like he exercised, he did all the things he's supposed to do to live right. But this stress had a tremendous effect on his life and overall well-being. And if you think about how, that's that's going to affect his kids long term, those are things that we have to consider in society. A lot of people think about, racism as this horrible event that happened, and this horrible event that happened that we can move on from, but everyone can't just move on from it. What happens, when this happens over and over again? What do you do? How are you meant to go on? How do you function, right? And as a father, when you're supposed to be the one protecting your family and they have to see you in these conditions, that really ate at him. And he was a joyful guy. Like he was a joyful guy, a great guy to be around, just full of energy and life. And he spoke about how our project really gave him a purpose. And so he felt he had a voice and purpose in the community. He was revived by the involvement in the project that we did. Now, I know that story was probably hard for a lot of people to hear and see, but it's the day-to-day life for a lot of people across the country, racialized minorities in particular. This graph shows the impact of racial discrimination and how it can lead to poor health outcomes. It kind of aids in the original root causes slide that I showed before. So racial discrimination leads to denial of goods, but also think about the psychological effects. And so the psychological effects are something that it increases cortisol levels, C-reactive protein, all these hormones that race through the body to help you deal with an immediate threat, which is perfectly normal for your hormones to increase in stressful environments to deal with the immediate threat. But what happens if you're stressed at home and you're stressed at work? Your body never comes back to a level of homeostasis. And this leads to higher rates of cardiovascular disease, decreased birth weight in babies, and increased risk of blood pressure issues, as well as physical injury from assault. So as you saw in the video, Ahmed, he was tased, pepper sprayed, all these things he experienced, these type of assaults. And he was completely innocent of all of those accusations that was made on him. Okay. So this is kind of just a rundown of some of the health disparities that are across the UK. If you look at diabetes, Scottish Diabetes Survey in 2019, type 2 diabetes were more common in South Asian populations, even at a younger age compared to their white counterparts. 73.6% of Black adults were considered to be overweight or obese. 2016 to 2017, cancer diagnosis decreased for all groups except for Black and other ethnic groups. In England, Black, African, and Caribbean ethnic groups had higher risks of hypertension. So if you think about these chronic illnesses and various comorbidities, it's definitely related to, the stress that they experience in day-to-day life. a lot of people talk about health behaviors and okay, people need to eat better and exercise. And I think that, of course, from a health standpoint, everyone needs to exercise. Everyone needs to, have a balanced diet. But there's a role that stress plays that cannot be denied. And I think that's something that we have to address in our society. When we talk about dealing with structural and institutional racism, stress is a component of that, is a result of those racist experience. Okay, so now we're going to move on to gynecology. All right, so we talk about the history of gynecology. James Marion Sims is an American physician. A lot of you probably have heard of him. There were statues of him. He's known as the father of modern gynecology. Right? They even name different devices after him because they were his inventions. They call them the Sims specula. Right? So they use these things in gynecological practices today. He developed these techniques on enslaved Black women without the use of pain medication. Till this day, Black patients are seen to be able to endure more pain than their white counterparts. This is not true, but it's an assumption that physicians still have today. There was a survey just done a couple of years ago, and they surveyed medical students, and they still held this bias. Mind you, Marion Sims, created, did his research, right, in the 1800s. Why do we still have these type of problematic thoughts today? Maternal mortality in the UK in the US show that Black women are more likely to die from pregnancy-related complications than their white counterparts. The Embrace report showed that in the UK, Black women were 4 times as likely to die compared to their white counterparts. And the CDC, which is in the US, showed that Black women died 2 to 3 times higher the rate. And famous people like Serena Williams and Beyonce experienced complications during pregnancy. And Serena's case stands out so much because she was dealing with she had a blood clot, right, embolism, and she knew what it felt like in her body because she suffered from these things before. And she had to advocate for herself because when she told the nurse what she needed a heparin drip. The nurse was like, "Oh no, just go lay down and try to brush her off." But Serena, she's not gonna just take that and go with it. She persisted and make sure that it was addressed, adequately addressed. But what about the patients that can't advocate for themselves or feel like, well, the doctor said I'm okay, I must be all right. Even since I've been doing this work, I run into patients that had issues where they delivered their babies and they said they were in immense pain. And the doctor was like, "Oh, you topped out of your pain medicine," and they sent them home. And they actually never passed the placenta. Like, what? Like, they sent them home and they could have died. Right. So this type of medical neglect happens not only in the US, but also here. During the pandemic, Dr. Jeeva John and myself, we did a research study where we interviewed racialized minority women in the Lothian areas who were receiving maternity care during the pandemic. And their experiences really mirror what the data was, showed us before in other areas in the US and in England about their voices not being heard, being treated differently. And so we broke it down in these 3 different sections. So institutional racism, here's a quote from one of the patients. It said, "And when they've asked, they have refused to stitch it back again. And they just told them to keep taking painkillers because they were in huge pain. And my friend, I've seen her, she couldn't sit." Right? So you think about being in pain and you can't even sit. And they're just like, "Okay, just take the Tylenol," right? But they're not addressing the root cause of the issue, right? Personally mediated. The patient said, "Like if I had really bad experience with my first one, meaning her first baby, maybe I would have thought the same and maybe I would have delivered in India or something." So to say that, the NHS is as great as it is, this patient said, if I knew I would have such a terrible experience, I would have delivered back in my home country, right? Internalized racism is like, "Oh, it's nothing that serious." Like, so we say, "Oh, it's nothing that serious." We, try to downplay it. But at the same time, there was a white woman who were having the same issue, but being taken more seriously. So they're noting that there's a difference in the treatment of how she's been treated as a woman of color versus the white counterparts. And again, the reason I show this data because this is something that is in Scotland. This is something that's very local. This is not, oh, that happened in the US, oh, that happened in England. This is something here. So it notes that these are issues that we need to deal with within our practices now. So this is a section where we talk about what's possible. How do we address these issues? How can we do better, right? Some of the suggested pathways that have worked in other areas is conduct internal assessments of the barriers against providing equitable care. So what are some of the challenges that people are experiencing, and why can't they get, why aren't they having equal access to care across the board? There's a racial equity impact assessment. It's a systemic examination of how different racial and ethnic groups will likely be affected by proposed actions or decisions. Now, this is actually something new to the US, but they've been using it across the UK for well over a decade. And so it's pretty much taking the time to say, okay, we're thinking about implementing said policy. How will it impact all groups? Okay. One of the practices that kind of highlighted during the pandemic was that everyone was supposed to have access to the vaccine, but it showed that certain groups, didn't. It became a challenge. There were barriers there. When they showed up to get the vaccine, they were asked for their address. So what does that mean for refugee and asylum seekers when they don't have an address, or if they were afraid to be deported, or if they were coming from an area where they were being tracked, they wouldn't want to be a part of the track and trace system. So if you think about some of the challenges that certain decisions that were being made and how it impacted certain groups, it's important to do that reflection before proposing a policy, right? Doing that exercise to make sure that it is equitable and it doesn't disadvantage any group. A lot of decisions that were made throughout the pandemic did not consider all populations. Even looking at the first data that was released, it didn't include ethnicity data. It only included gender and age. It didn't include ethnicity. So when that data on ethnicity was finally released, it highlighted that there was a disparity in how groups were being impacted by COVID-19, right? Another way is to create a supportive culture of safe reporting. So if you think about, if I experience an issue, do I know where to go to report? Okay. And if it is reported, how will it be addressed? A lot of the times people don't report issues of racism because they're afraid to be targeted. And if they, report a person, how do they know they're going to be safe? This is an example that they have. It's called Speak Up for Black Women, and this is like Speak Up Action. So you set limits, allow only racially respectful speech and action in workspaces, practice and prepare. So plan how to act if a conversation is disrupted, if someone's being disrespectful in a conversation. And I used to do this in my classroom actually. So if I knew I was going to be talking about a touchy subject, I would start off the conversation. I would start off the lecture saying, okay, we're going to be respectful of all voices, or, this person, you may be asked to leave, right? Because we want to make sure that everybody feels safe and to speak in the space and no one feels targeted or ostracized in any way. Express your concerns. So be bold and clear and straightforward. Discuss why you are concerned. Apologize. Say you're sorry. Change your behavior, right? So if you know you've done something wrong or someone came to you to let you know that this was wrong, apologize. Don't be afraid to apologize. Sometimes people think that admitting something was wrong is, it's a big step for them, but you can't move forward if you don't admit the wrongdoing. Keep improving, be courageous, become aware of your impact and explicit bias, right? Uncover and learn. Sometimes you just don't know. So it's important to be curious and be mindful. And some of these things are constantly shifting. So it's important to keep reading, right? And persuade others. If you know that someone has problematic thinking, try to persuade them to think differently or better understand their coworkers or the patients they're working with. Data infrastructure. I'm a big advocate of data. I'm a social scientist, and I think that if you want to advocate for change, data is definitely going to be one way to do it. You know, you have to have clear data to say you want to address either health disparities or any type of inequality. So clear data is going to be important. Establish patient quality and safety infrastructure and monitor and evaluate for disparities. Yeah, so if you have the data, you'll know which group has been disproportionately affected by something. There are certain countries in particular that don't have race or ethnicity data at all. So their assumption is, oh, we're doing all right, but they're not actually doing okay. They're just ignoring that the problem exists, okay? And then I'll just say the last one is advocate for a patient voice. So, you know, advocate for the voices that are not in the room. So in conclusion, anti-Black racism is a global problem. It's not something unique to Scotland or the UK. It is a global problem seen throughout. COVID-19 pandemic highlighted a lot of the disparities across the UK that some people were not aware of. And I think that that was a moment there for, you know, increase awareness and to kind of put your feet on the ground and say, okay, this is what we're going to do. We're going to move forward. We're going to listen to communities and, you know, get guidance from the people that's dealing with these challenges from day to day. Health is not there solely in the hands of the individual, but the environment and the conditions in which people live and work that shape the health behaviors. So if you think about why you're able to get up and go for a run every day, why you're able to eat, you know, a balanced meal with fresh fruits and vegetables, right? Think about that environment. Then you think about the environment that other people live in that don't have a safe space to exercise. One of the major things under the pandemic, a lot of racialized minorities didn't have access to that, you know, the green space to go out and exercise. Yeah. So this is just a list of some of the books that I pull from, I've been trained in, and it will show, you know, it will kind of give you some deeper information around systemic racism. Eduardo Bonilla Silva, his book on racism without races, I think it's really good because a lot of people say, okay, particularly when Barack Obama was in office, you know, President Barack Obama, when he was in office, they were like, okay, America's a post-racial nation. We no longer have to deal with race because, you know, we have a Black president. So it's done and dusted. We've moved on. But the structures are still in place. And it clearly shows that, you know, having a Black president did not directly change the lives of racialized minority across the U.S. Yep. Joe Fagan, Systemic Racism, I spoke to earlier. Tommy Curry, the book The Man Not, really focused on Black manhood and how Black men are seen as vulnerable, and the cases of Mike Brown and Trayvon Martin, how these, you know, these Black men were seen as like superhuman strength, right? They're always like stereotyped as being very strong or angry in some sort. Think about the case of Ahmed, who was just walking with his family and he was, you know, constantly harassed by the police. So his book kind of deals with that. Deidre Cooper Owens, her book on medical bondage was really good. He talks about the history, the origin of gynecology, and it kind of just gives you, you know, something to think about when we talk about how our medical practices are done today and what they come out of. And as well as Harriet A. Washington's Medical Apartheid. She goes through the history of medical experimentation on Black Americans from the colonial times. And so, you know, some of the things we enjoy today were at the expense of enslaved bodies and prison bodies. And she talks about some of that. And this is a new one, Decolonizing Public Health Through Practice, the Impact of Black Health in the UK. You know, it's a way to decolonize public health practice. So just reflecting on how the colonial past influences the way we practice medicine today and some corrections that should be made. Thank you very much. If you have questions, feel free to email me at gwinnetta.curry@ed.ac.uk. Thank you.
Gwinnetta, thank you so much. That was so insightful. Thank you ever so much and so fascinating. We can stop the recording now, if that's okay, Adi, so that we can allow people to ask questions. Also, just to flag that apparently there are still some people in the waiting room. We can't managed to let in. Mark, if you could